So thank you for coming. Mr. Burt.
Yes, thank you. Thank you all for joining us. Thank you to those who are watching away from here, but joining in the conversation. Like Dr. Linder said, I encourage questions. We're going to do this a little different way. I've watched a couple of the courses. I think everybody does it a different way. So what I'm going to kick off with is a bio of our panelists, very brief bios of each. And then I'm going to allow them to have sort of a 30-second preliminary message on kind of where they're coming from. As you'll see, we have a panel that's made up of individuals from the medical school arena, the School of Public Health or Community Health, someone who trains residents and fellows and sees medical students, as well as those who continue to train those that are already in practice and looking at team-based care. And that's really our focus in trying to figure out, as we look at the future, where are those gaps? Are we training appropriately? Because I think as you look and you see more and more medical schools or you see more and more allied health schools and the team-based approach takes a different look, are we doing the right thing by just adding more, or are we focusing on what we really need to and collaborating and making that team-based care efficient for patient care for the long run? So I'm going to start with over to my left. Dr. Stephen Brown currently serves as Chief Clinical Officer and Associate VP of Clinical Strategy for the Texas A&M Health Science Center. He's also Chief Clinical Officer and Professor with A&M College of Medicine. Dr. Brown was formerly Vice President of Clinical Operations for Trinity Health Provider Network that employs over 7,500 providers in 22 states. Before joining Trinity Health System Office, his service included VP and Chief Medical Officer for Trinity's St. Alphonsus Health System, again a 4-hospital system in Oregon and Idaho, and president of the 400 providers in that medical group. So a wide variety of clinical operations experience there. He may look familiar to you because he used to be right here in the Med Center after concluding a 19-year career with the University of Texas as an associate dean and tenured professor at McGovern. He holds two degrees from Texas A&M and received his doctorate of medicine from UTMB in Galveston. He's board certified in internal medicine with added certifications in pulmonary and critical care medicine. Next to Dr. Brown, we've got Dr. Nana Coleman, who serves as the Assistant Dean for GME and Assistant Professor of Pediatrics Critical Care at Baylor College of Medicine. She's a practicing pediatric intensivist at TCH and also the Education Director for Team Launch, which is the institutional interprofessional teamwork course at Baylor. So as you can see, kind of as we look at that team-based approach, really having you on the panel is significant there. Dr. Coleman earned her undergraduate degree from Harvard, subsequently completing a master's degree in education at Harvard, and then medical school through Dartmouth Brown combined MD program in getting the degree from Brown University. She has formal training and extensive professional experience in healthcare quality, patient safety, teamwork, and medical education. And the research has focused primarily on the evolution and development of teams in complex healthcare environments. So as we look at that focus as well, your piece will be very important. To my right, Dr. Robert Morgan is professor and chair of the Department of Management Policy and Community Health at UT Health Science Center School of Public Health. He received his doctorate from the University of Texas at Austin in 1983, specializing in psychometric measurement theory, and has been active in health services research for more than 30 years. His teaching and research focuses on how health system organization affects access to and outcomes of care. And then finally, Dr. Jessica Uriarte currently leads the Office of Academic Development at Houston Methodist Hospital. She holds a doctorate of public health from UT School of Public Health and did her postdoc research in quality improvement and education in the Department of Veteran Affairs. Currently holds faculty positions in the Institute for Academic Medicine at Houston Methodist as well as Texas A&M School of Medicine. Her research is in interprofessional team training methodologies, and she's been instrumental in developing curriculum that run across disciplines to address a team-based approach to care in an academic environment. So as you can see, a very nicely put together panel. I encourage feedback. I encourage a dialogue. I don't want us to just keep speaking up here because I think what we get from you will also lead some of that conversation. So I'm going to turn it over to Dr. Brown, not to put him on the spot first, but for a very brief 30-second overview of, from his perspective, What does the future of team-based care look like as it relates to a medical school environment?
You know, I trained students, residents, and fellows for almost 20 years. And then I was in integrated healthcare systems, managing medical groups and trying to put together clinically integrated networks and accountable care organizations. It was really then when I realized we're not doing a very good job back on the education. So I've returned to A&M to work for Dr. Carrie Byington, who has committed the A&M Health Science Center to interprofessional care, particularly in its mission that addresses military, including VA, as rural health and primary care. So what I understood is that the trainees that I was hiring, and I hired hundreds of physicians and nurse practitioners and PAs, that they were not well equipped to work within a team. They didn't know how to acknowledge one another, respect one another, and actually get the work done of population health, including wellness and chronic disease management.
Great, thank you. Dr.
Good
Coleman?
evening. It's my real pleasure to be here. I'm looking forward to the conversation. So the lens that I bring to it is both as a clinician and that of an educator. So I would agree with Dr. Brown that there is an opportunity for us to grow in the way in which we're training future clinical providers. I say that because when I first started looking at teams and how teamwork and teamwork skills affected health outcomes, it wasn't always clear that there was a direct link across all areas. What we've found now over some years of doing this work is that not only does the performance of the team impact how well patients do, but it also impacts the people on the team. And that is the critical link between team and health outcomes. Of the characteristics that I think are most important as we look toward the future of training in medicine, thinking about values that matter to the patient, thinking about values that matter to the providers, thinking about actually developing teamwork skills as a core professional competency, right up there with all of the clinical skills that students and house staff are learning. And then ultimately thinking about how do we inform and arm the public with the right expectations for their providers, such that at the end of the day, the paradigm of the team moves back into a situation where the patient and the family are at the core, and that the healthcare system and providers support those people in the center. Thank you.
Perfect, thank you. Brown? Sorry. Yes, Morgan, Dr. Morgan.
So first I wanted to thank Dr. Burt for having me on the panel, and thank Dr. Linder and Dr. Garson for allowing me to come and speak to you guys tonight. The Institute for Healthcare Improvement has noted that taking into account all of the preventive, chronic, and acute care that a primary care physician needs to attend to for their patient panel would occupy close to 24 hours in their day. And so it's no wonder that only about 50% of patients get the recommended care across all of those areas. My lens tonight is both as the chair of a department in the School of Public Health, where we look at the organization and delivery of care and how care financing impacts the operation, the success of that delivery. I'm also talking to you as the husband of an overworked primary care physician who gets to hear his wife complain every night about all of the things that she sees burdening her in her attempts to deliver quality care to her patients. And I'll just stop there.
Great. And Dr. Uriarte.
Hi, I am so thrilled to be here with you all and be part of this really dynamic discussion and with these very esteemed panelists. Thank you, Dr. Burt and Dr. Linder for having us. So I lead the Office of Academic Development at Houston Methodist, and my job is to help our clinicians and researchers to be better teachers, better mentors, and better scientists. And often what that means is that I am in the front lines rather of teaching individuals from very different professions to collaborate together for perhaps the first time. And so I'm very familiar with the cultural differences between each of the professions that might operate in a hospital. As any of our panelists can tell you, if you walk into a hospital unit and ask someone who is on my team, the nurses are going to point to the other nurses and say, these are the people on my team. And the doctors are going to point to the other doctors and say, these are the people on my team. And so trying to have that conversation around a team-based approach to care in a way that allows for each profession to articulate what their role is sort of how I spend my days. So my doctorate is in public health, and my postdoctoral work was in quality improvement. So I see health from a systems perspective, and it informs my conversations when I'm talking with individuals from different professions that see things as a siloed approach to care. So I'm excited to be here.
Good. Thank you all. So we're going to jump right in. Again, I encourage questions. I encourage you to interact with the panelists. Just raise your hand. I'll call on you, and we'll do that. So I'm going to jump right in. We hear a lot about supply and demand. We talk about primary care practitioners, whether that be physicians, allied health practitioners, whatever that may look like. We're seeing more medical schools. I talked about that a second ago. We're not seeing a whole lot more residency programs at the national level, and kind of how does that fit in as we start to train? So the first question is going to be to my left, and jump in whoever would like to go first, but are training institutions adequately training the quantity and type of healthcare providers needed to address or meet the healthcare workforce for our future? Who wants to jump in first? Dr. Brown, you want to jump in?
Certainly. I think there's three elements to the question. One is adequate, second is quantity, and the third one is really need. And I will restrict my comments to medical school since I spent a fair amount of time there, and suggest that the adequate training is no, it's not preparing for the future, as I mentioned before. They're not preparing for value-based environments, teaching to what that means, and are not reliably patient-centric. And I think that those are the problems. Medical schools often have an interprofessional education plan that's been around for 20 years. It's not new. The difficulty is that it's not really been translated into residency programs reliably, and it has not become a part of their future. So it's like me taking 2 years of Spanish. I'm pretty good at the end of 2 years, but if I don't continue practicing it, I lose that skill, like any kind of skill. On the quantity, I'm going to argue, and this is maybe heretical as a medical school executive, that there's adequate quantity of at least medical students coming out. I do want to highlight exactly what you said about inadequate residency numbers, and that's catching up with Texas. Nebraska was actually a perfect example of teaching a lot of students not having enough residency, or they were a net exporter. You could actually calculate the next net export of money and government support that went to other states because they didn't have residency programs to retain it. For 30 years, it's been true. 75% of a residency residents will choose a site within 250 miles of their last training site. So they really will regard that as a home base. I think in nurses, definitely not training enough of them as well. I think techs, probably not, and I think that there's some good statistics. But the problem, at least for physicians, is that you have a geographic problem, what I call horizontal. They're not being distributed correctly in geography, rural health being a good example, and a vertical problem. This is that they're not going into primary care where we really need to have the efforts being made. And there's a lot of excellent reasons that people don't go into that, and a $150,000 debt at the end of school is a big one. Now, in terms of need, I think the real need is we need to have population-centric kind of educational programs and curriculum and perspectives. And I think if you will actually manage the populations well, that will actually reduce utilization. And I think that most people agree 25 to 30% of the healthcare dollars is wasted in care that's unneeded.
Thank you for those very thoughtful comments. So I'll approach my response through the perspective of training house staff, residents and fellows, because although at Baylor College of Medicine and other institutions there's a continuum, I think it's important to think about Dr. Brown's comments in the context of the continuum of medical education. So I would also agree that we are not necessarily training adequate trainees of the future in terms of number. quantity and need, but I'd like to approach it from the perspective of core competencies. I want to ask, has anyone in this room heard of the Clinical Learning Environment Review Program, or CLEAR, by show of hands?
Raise it high, like 2 people.
Okay. So I won't ask you to share what it is, but I'll give a little bit of background for those of you who may not be familiar with it. So the ACGME, which is the council which accredits graduate medical education or resident and fellow training, in 2012 recognized that this very issue was very salient, that we were training physicians with the expectation of being well able to execute core clinical skills, but that there were areas of opportunity. We recognized that when physicians were going into practice, by public demand, that they were lacking in knowledge and skill and competency in areas of quality improvement, patient safety, transitions of care, supervision and accountability, wellness, and professionalism. All areas that, in some instances, some would consider soft, but what we've now realized are really the key skills that underlie anyone who wants to be successful as a physician. When I train residents and fellows in my specialties of pediatrics and critical care medicine, I always say that I'm happy that you can intubate a patient. I'm happy that you can put in a central line. But at the end of the day, when we're having an end-of-life discussion about the fact that we're not going to be able to continue life-sustaining support for a child, I need you to be able to speak professionally, have accountability, and understand how the resource utilization for this patient affects our health system. And we're simply not teaching that. Through this CLEAR, or Clinical Learning Environment Review Program, the council, the ACGME, decided to begin surveying residency programs and fellowship programs through the sponsoring institution to understand how well are we meeting core competencies in these areas. What they further recognized was that that process should not alone live within the medical school or the sponsoring institution, i.e., where does training occur? Not within the bounds or offices of the school, but in practice at the clinical learning site or the clinical learning environment, be it the hospital or the clinics. So through this program, what we've learned is that we've made great strides, but that the work ahead of us is significant. 3 areas that are coming up in the next cycle of ACGME requirements for competency are teamwork, interprofessional practice, and collaborative learning. Because as we round out the expectations for the physician of the next generation, we understand that those core professional competencies will underlie their success. One of the challenges that I see is, how do we get this work done? Speaking from our own experience at Baylor College of Medicine, working in the biggest medical center in the world, we have faced challenge. How do we make sure that our almost 1,450 learners and our faculty that are more than twice that amount acquire those skills to teach them, impart them, and make sure that it's not something that they turn on and off, but it goes throughout the continuum of training? How do we make sure that our house staff, whether they're at Texas Children's Hospital or rotating at Baylor St. Luke's or the VA or Ben Taub, are learning the same thing? And how do we make sure that their knowledge acquisition isn't just enough to pass for the test or the accreditation visit, but enough to sustain them into their careers? So I pose that as a point of discussion as we enter this discourse over the next little bit, because in summary, we are doing better. We've recognized that there are gaps and that there are opportunities, but we certainly have ways in which we can move forward.
Great, thank you. So I want to jump over here and not lose topic over here, because with Dr. Morgan's piece of being community health, we live in a very rich environment in the Texas Medical Center. We have a lot of trainees. It looks like a very great place to train. It is a great place to train. What we don't see a lot of or hear a lot of from our perspective as we kind of go up into our high-rise buildings is from a community perspective, community health perspective. What are we looking at in regards to either healthcare teamwork shortages or opportunities maybe for those collaborations when you're not in that type of an environment like a Methodist or a Baylor CHI hospital?
Well, I think it goes back to what Dr. Brown and Dr. Coleman talked about, which is assuring that medical residents, when they come out, are actually trained in the types of skill sets that they're actually going to be using in practice. Most medical residencies are picked by physicians coming out for a variety of different reasons, including, importantly, financial reasons. And I think that part of the challenge that we have from a physician point of view in terms of is to find a way to incentivize medical students towards choosing a primary care-based residency program and towards choosing and then providing residency programs that are community-based as opposed to located in academic institutions. The second thing is going to be integrating other types of healthcare providers in with the residency program. Medical students have a lot to learn in medical school. Residents have a lot to learn when they go out into their residency programs. Most medical residents really, when they finish their residency programs, most of the ones that I'm familiar with, really don't have a good feel for the range of practice opportunities and the range of practice needs that they're going to run into in the real world. And so it is kind of an accepted fact that at least in primary care specialties, new primary care doctors will change their position. About 50% of them will change their position within the first 2 years. This is something that really needs to be addressed in terms of acquainting medical residents with, or pairing them with the opportunity to work in practice environments that are going to more effectively mirror what they're going to be needing to do in their practice lifetime. So,
Thank you. And Jessica, as Dr. Coleman pointed out, teamwork, interprofessional work, collaborative learning, all the things that you focus on, and talk a little bit about when you're looking at it from, just use Methodist as the example, and you're doing your courses, what types of learners are you getting, and what is their feeling about not only interprofessional work, but this collaborative model of, like you mentioned, nurses thinking that's their collaborator only or their team only, when we need to get to this model of it's a pharmacist, it's a PT, it's a physician, it's also a nurse, and how do you build that?
Sure. And I would echo what each of the panelists have said before me. I think that we celebrate some of the advances that we have made towards recognizing the need to train individuals as they're coming up with this idea, ideally training individuals from different professions together, training them at the same time. And we've done some really remarkable things, progress in that area. One of the challenges that I think we've touched on a bit is the tide of culture that individuals that are coming out of training will encounter. So they go through it, and for a medical student, for example, they'll finish medical school and go to residency and perhaps have a fellowship, and then be working diligently on a floor and be faced day to day, not with the echoes of an understanding of how team-based care works, but the realities of how that floor operates. And if those senior faculty or senior practitioners of many professions are still entrenched in their own understanding of a more siloed view of professions, collaborating together where nurses are still with nurses and pharmacists are still with pharmacists, I think it's very difficult to swim against that tide. And so one of the things that I work on is working with our senior faculty or senior practitioners to make sure that we are giving them a buy-in, a reason to change their behavior. I study how individuals learn is my research, and so if you've learned something, you've done something for 20 years one way, unlearning it is one of the most difficult things to accomplish. And so making sure to articulate the reason why we work in collaborative teams. And thankfully, I think it was in 2015, there was a meta-analysis done recently about how interprofessional team training, such as the Team Steps program, enables us to save patient lives, right? When you're speaking with someone, trying to give them the buy-in, speaking with them, giving them the currency that they're looking for, right? If I'm talking to a physician, if I'm talking to a clinician, they care about keeping the patients in optimal health. They care about making sure no one dies. And so if you can articulate doing these, as we talked a little bit about soft skills, right? If you can translate this idea of improving team communication and describe it as something that this could mean the difference between life or death for your patient, you get that buy-in, even for those individuals who were not trained in a collaborative model. So.
Great, good. And I want to piggyback on there because we see learners coming from various schools. And I know speaking from a medical student perspective, now that we've got them, we don't hear a whole lot about them doing a lot of interprofessional work. They're siloed, they've got a short time frame to get in and out of the preclinical years, get into their clinical environment and start gear up for residency. Only then I think they're a part of a real medical team, but I don't know that they always know their place. So as you look at that, how do we, aside from sitting in some of these courses, how do we collectively co-train medical students, nursing students, residents and fellows, et cetera, community health providers, in an environment where you don't have to take them out of their clinical environment? Because we all know that RVUs for physicians and all these other things that are driving the whole financing piece, and y'all have already gotten that, but how do you make it worthwhile, not only for the team person, but also for the institution? Because ultimately it impacts patient care, and ultimately it's something that's going to impact the institution. So how do we do that collectively without feeling like you're taking them out to do a course? Yes,
I can
absolutely.
share a little bit about our experience at Baylor College of Medicine that some of you may be aware of. So I'm going to acknowledge up front that I'm shamelessly plugging an amazing team that I have the privilege of leading and working with at Baylor called Team Launch. So some years ago, as we were going through our accreditation process as a health sciences institution, we recognized that this was a gap. And we have a graduate school of biomedical sciences, a school of medicine. We have an allied health school that trains individuals at the both master's and doctoral levels, and also a school of tropical medicine. And this was the issue before us. How do we take these amazing, great students who could easily walk through their education at Baylor College of Medicine and never learn anything together, and actually help them to acquire skills and training and teamwork, but to learn from each other? So out of that was incepted Team Launch. I credit some wonderful people, Dr. Alicia Monroe, our provost, and others who really took the helm to make sure that there were resources available to make this happen. So what this is a course that is an interprofessional course by design. We bring students from all of these disciplines together in an actual teamwork training course. There are many components, some which are restricted to students, others which are open to faculty and actually the entire TMC community. And through that, we try to propagate the mission that teamwork matters, not just within the clinical realm, not just within the laboratory, but across the board. What has been a challenge? The challenge is, how do you do it not just outside, as you've said, of working hours? How do you do it so that it seems to resonate with everyone? And so I'm happy to say that we are nearing consensus and have actually achieved consensus on the fact that for all of our incoming students beginning in the next year, Team Launch is going to be a requirement. We will inform sort of the students coming in that this is a priority. It's one of our values, and ask for their engagement as to how we make this happen. The exact logistics is right now what I would call work in progress, but we have agreement that this matters just as much as the training that they receive in any of their disciplines. And so just with credit to our deans, Dr. Krishner, Dr. McLaughlin, Dr. Smith, and others in really making this possible, Dr. Gill, really exciting. And so I think it is doable. It requires a lot of work, a lot of support, and a willingness, but it's essential. It's necessary.
Okay. You feel that? I mean, you've got pharmacy, medical students, nursing students from.
So we have 5 colleges, and again, interprofessional education efforts have been around for a couple of decades. So the difficulty is the end product really capable of performing? And I say the end product, I'm talking about whether it's any of those professionals, do they, when they enter their profession and are completed with their training, can they actually function in a team environment? Mm-hmm. And I argue that my observation is they don't. And my experience is that they have difficulty in doing that. And that's critical because physicians have a burnout rate of about 30%, and I think most of it is self-imposed because they feel like everything has to pivot off of their decision-making. And creating a team-based environment means everyone is working at the top of their license or at their certification, and is removing some of that burden and beginning to automate some of the care, particularly around wellness. So what A&M is doing is, besides IPE, Interprofessional Education, which takes all the 5 schools and puts them together, is it's beginning an interprofessional practice plan. This is a little step forward because we're actually taking the 5 schools and saying, at the faculty level, you have to practice together. And we're creating new practice sites and environments with particular goals around population health, quality, reduction of utilization, that's the value equation, quality divided by cost, to achieve those ends, and you have to respect one another to bring those, your skills, and that no one's at the top, and each one's got a particular role, particularly using a team-based type model. And that's where that's starting, is to make certain that the faculty are aware and they themselves are practicing, so that the trainees will emulate what they're seeing in their faculty.
Could I ask
Yeah,
a
absolutely.
general question that maybe we can come back to? So I appreciate what you've said about the framework and the heuristic of how do we bring individuals together. What I would be interested in our discussion and the audience going back to is, how do we know if it's working? We have had a really great, robust assessment team led by Dr. Nancy Moreno at Baylor and others, through which we've developed rubrics that have actually panned out to say, in our small but meaningful numbers, that it works. And so I would really be grateful from input from the panelists and team as we go forward in knowing how do we actually measure that this is worthwhile. So thank you for raising that.
Yeah, go ahead. Just state your name and where you're from also, so we know.
Hi, my name is Shanae Hall. I teach part-time for UT in the nurse practitioner program, and I work at the VA. I've had the pleasure of the last year and a half to work as a trainee and now as faculty in their interprofessional education model in primary care. So they have a program that's built on 5 legacy sites and other primary care centers around the country and other VAs where we do train residents together. We have medicine interns, residents, nurse practitioner students, nurse practitioner residents, mental health, social work, that's the one I'm forgetting, and pharmacy. They all rotate through. Among the attendings, we all have our own panels, and then our residents have panels underneath us, and we all see patients and kind of co-manage them together. And the beauty of this is we have one large room that we sit in as attendings, and the residents come in and we can call on our, hey, pharmacy, I've got some questions about this patient. How can we do this together? And other sites that are further in their process than we are have done a lot of work in some evaluation tools about how does this work and how does this work for patient outcomes. So that's one place you could look for those items. But just how we've had a lot of really complex patients that have been put in our panels because they need that intensive management. They're really chronic disease, don't have a lot of support, homeless, substance abuse, mental health, those kinds of things, on top of their uncontrolled diabetes, high blood pressure, maybe they've had an amputation. And we've seen some reduction in ER use. We're really just starting to track some of that now because of the way we've had to build panels. And so it's really encouraging to see learners crossing back and forth in our medicine residents going, oh, I didn't know nurse practitioners had to know how to do that. Or, oh, your pharmacist can manage that for you? Yes, they can. And so it's great to see everybody practicing at the top of their license and to their education, and then learning from each other to understand where our education differs and how we can better educate each other.
Yeah, that's great. Thank you. Yeah, I remember a few years ago we did our internal survey that we do for residents, and we got really low on something about interprofessional teams, and we kind of dove a little deeper, and we're like, residents, y'all work with interprofessional teams? They're like, no, not really. And we're like, well, ever work with a nurse or a pharmacist or this? Well, yeah, we do that. I'm like, that's that. And everybody should be at 100% with that because they are. So thank you. Good. I saw a microphone be passed. Perfect. Oh, at the back. Yes, go ahead.
In the back. Chuck Begley, UT School of Public Health. From a health system point of view, I'm wondering, as we move ever so slowly towards some kind of healthcare reform, better integrated care, are you guys in your positions getting any sense of increased demand for clinicians who have formal training and experience in team-based, collaborative, integrated care? I mean, is there anybody out there that can say that, locally, that the Harris Health System or Memorial Medical Care System or Baylor or UT Physician Practice Plan, Scott White, are they out there saying, we want to hire 5 new primary care physicians this year, and we're prioritizing that they have a formal training in integrated care? Do you ever hear that?
Well, yes, and I'll give you the perspective from Trinity Health, which is the second largest faith-based system in the United States in 22 states. And the remarkable thing I realized, it really depended on market. There were some markets where it absolutely had no value, and you ask them what's going on there. It says, well, we're just sort of fee for service here. But in Michigan, as a good example, the Northeast, Connecticut, and Massachusetts definitely are looking precisely for that kind of individual who's really prepared. But honestly, let's just go back in time. Kaiser Permanente was the example that demonstrated, one, it works, and two, it's in demand. And there's several others, whether it's Geisinger or Presbyterian in New Mexico or Bon Secours or a host of others that really have already done this. And they are selecting the correct phenotype to start with. So, the rugged individualist who wants to be wholly autonomous, next please, in the recruitment process.
Anything from this side, or are you?
No, I'm impressed with the program that A&M has going, and I'm happy to hear about it because, from my perspective, residents need to be embedded in those environments to actually learn how to perpetuate those practice styles. My concern, I guess, gets at something that I think Dr. Begley was driving towards, which is sustainability in the community. And most medical care does not happen in academic medical centers. It doesn't happen in training environments. So there need to be places that these residents can go once they graduate that will be receptive to team-based concepts of care. And there need to be financing systems in place that are going to sustain those systems.
Great, thank you. Is there, I knew there was another question.
Hi, I'm Pearl. I'm a medical student. In UT. So we have, I was part of an organization called Student Intercouncil, and the whole purpose is to be representatives of each of our 6 schools in UT Health. And the idea is to foster interprofessional interaction and education, really, about what we do. So there's 3 representatives from each of our 6 schools, just for everyone here. That's medicine, nursing, dentistry, biomedical informatics, biomedical sciences, and public health. So there's at least 3, and then they have 3 specific spots for underrepresented students and 3 additional spots for international students, so that everyone's voices are at the table. And through this organization, for example, like this Friday, we're having a crawfish boil, which is like a nice way for us to socially gather and kind of foster those conversations, which I think is almost as important as what y'all are describing about working together. Because I think, Dr. Brown, you mentioned like we, as like MDs, are perpetuating the hierarchy in a sense, and we are still operating at the top of it, when in reality, if everyone's practicing at the top of their license, and they're technically at the top of the hierarchy, like kind of this more ideal of a flat structure. So anyway, there was a student-run initiative. Margaret Wing is an outgoing 4th year at my school, and some of her colleagues put together a program called UT Health Cares. And on February 3rd, we had a collaborative event where all 6 of these schools that I enumerated earlier were working together to serve at UT physicians in the Jensen community here in Houston. And it was the first time that we've done this, but that was a really beautiful way for us to see each other at the top of our licenses as students. And I personally got a lot of value out of getting FaceTime with the public health students, nursing students, et cetera. And that was fashioned out with stations that patients would cycle through. So I just wanted to share perhaps UT initiatives that are going on, since we have BCM represented here in Texas A&M that have shared from a student perspective about what's going on. I would also add that there are some like IPE online courses that they're trying to head up. I don't know if you're a part of that. I personally didn't get a chance to start in on that yet, but that's also really exciting. But I definitely see the value in it. I definitely opted into SIC, the Student Intercouncil, because I really see the importance of that. So I just wanted to share that. I don't really have any questions at this time, but I'm very impressed that the launch program is going to be integrated into the first year. I think that's a really big deal, because I think it says a lot about how the school is valuing IPE, and it's not just lip service. So thank you.
I think we see that from our learners. I don't think I introduced myself at the beginning, but I oversee the educational infrastructure at Methodist. And so I've got residents, I've got medical students, I've got a CME group with physicians. So I've got a variety of different areas. And I think what we've seen is kind of that push from our students and residents to figure out how to be part of the bigger team, which hasn't always been the case. And so it's nice to see medical students really interested in that. I want to jump. I'll be right. Yes, go ahead, and then I'm going to jump over. I don't want to lose the fact about wellness and burnout and kind of the public health impact of that, because I think that's critical as we talk about teams. So go ahead. Yeah.
This is a little bit about that. Shannon Kenyon,
Good.
iQuest Health Services Research at Baylor and VA. So you've spoken a bit about the value of the impact on physician burnout, the impact on turnover, and I wanted to ask you a little bit about the impact on the patient. Traditionally, there's been the patients found value in the time that they spend with their physician. Have you addressed in your team-based education the education of the patient? Have you had any measurement or impact on patient satisfaction with regard to the team-based approach, and have you measured that impact?
So, in my own experience, one of the most important education to the patients is the idea that the team is taking care of them, that they have greater access to not just their physician, they have access to the entire team. And that access actually takes three forms. One, you're seeing your provider. Two, you can access it through the team. And three is electronic, meaning that it could be telephonic, it can be by email. So this is a matter of we improve your access, but don't always call up expecting to talk only to your doctor. Again, it makes the physician a single pivot point when there's other team members that can manage a lot of questions that they may have. So it's not a strong arm, it's a matter of making certain that everyone understands their role in a team, respects that, and that the patient does too. So that's a part of education, but for them the benefit is greater access to the entire team. And yes, they do like it better. So CG-CAP scores do go up in those environments where it is team-based, it is well-rehearsed, morning huddles, team steps training, those kinds of techniques to make certain things go smoothly. And we used likelihood to recommend the practice as the hallmark kind of question in that. But by the way, what is the most important determinant of likelihood to recommend statistically?
Question for y'all.
So, no, actually there's one, the staff, two, the access, three, communication with providers. So of that, statistically, which one predicts likelihood to recommend? No. Communication with provider. There was a large study, it was over 250,000 surveys that were done, and if you do the regression analysis, you find out that that's the single most important element. So that's.
Flesh that out though. What does that mean, communication with provider?
No, that's the the patient's impression of how they view the quality of communication with that provider. There are some subsets in the Press Ganey, which is a typical kind of vendor that is used on that, but usually that's, when you roll it up, that's the subset score.
Okay. Is there another question? I think I got everybody. Okay.
I think Dr. Coleman had a comment?
Yeah.
Dr.
Oh, Dr. Coleman. Okay, sorry. Oh, go ahead.
So just a very micro level, I think of my work in the ICU. So I was one of the original TeamSteps master trainers when it first was incepted, and we talked about communication and how those skills affected quality and safety outcomes. And I looked at that for a long time. But the reality is, when I think of our day-to-day, how do we run rounds in the pediatric ICU? Family-centered rounds. And one of the tenets that I've written about is, how do you strike that balance between family-centered and family-directed? Because at the end of the day, patients want their providers to be their doctors, not their friends, not their, what do you think we should do? But at the same time, we need to respect the patient. And so the paradigm that I often think of is the patient and the family at the core. And I often say family because in pediatrics, it's never just the patient, it's also the family. And so when we looked at the satisfaction from our patients about their experience in the ICU, even when catastrophic outcomes occurred, even when their children died, even when they did not have the functional outcomes that any of us would have liked, they still, in consistency with Dr. Brown's points, noted that when they felt that they were heard by and had sufficient interaction with the providers, they felt that they had a good experience. And I can't emphasize that enough, because to your question, what does that really mean? When I think of a family leaving the hospital without their child, but still coming back to us to say, we had a great experience. And for them, that being typified with, we were able to be present on rounds every day. We were able to have the answers to our questions made available. There was transparency in the process. And above all else, we saw that you all functioned as a team. Because the times when the outcomes were poor would be when we don't feel the teams are talking to each other. We don't feel that we're being heard. And so it really does make a difference, both at a grand and macro system level, but also in day-to-day interactions.
Can I comment on
Yeah,
what
absolutely.
Dr. Coleman
Yeah,
said?
jump in.
Many years ago, Dr. Atul Gawande talked about the transition of a physician's role from a cowboy to a pit crew, right, to part of a pit crew. And I think that that analogy is glorious, and I use it all the time to try to talk through it. And thankfully, we're making a lot of progress in, for example, not hiring cowboys to lead a primary care physician or a primary care setting. And I think that as our policy changes, various policy changes come into place, regardless of what happens on a macro level, the efficiency of a primary care team is going to be, there's going to be more increase in needing to see more patients in a shorter amount of time to bring in more revenue. And you talked about a patient having sufficient time with a primary care provider. This gets back to everyone working at the top of their licensure, because someone who's a registered nurse is a great person to talk through. Let's say a patient with diabetes comes into a primary care clinic. A registered nurse is a nice person to talk to through about what to eat if this person has diabetes. But a community health worker is actually, we have a lot of evidence to say that they're significantly more effective at coaching through someone who is more like their peer, to coach them through what to eat. And they can spend that hour with a community health worker at a lower cost, allowing the registered nurse to do what he or she is able to do at the top of their licensure, and allowing the physician to see as many patients as possible. So it all sort of gets integrated together.
So how do we enhance that from a community health perspective?
Well, I think getting buy-in from the organizations like Methodist to incorporate community health workers in the process of care. I think that they're a remarkably underutilized resource, and as Dr. Uriarte, I'm trying to make sure I get the R correct. Uriarte. As Dr. Uriarte just pointed out, I mean, they are enormously effective when they're properly integrated into the process of care. And I think to the extent that we can expand that model, not just with community health workers, but with clinical social workers, with other types of alternative care providers, where they're actually providing care at the level that they are trained to provide, they can free up other practitioners to, as you put it, operate at the top of their licensure. And I think that the healthcare system really, it is moving that direction, and it, again, I keep going back to incentives. The healthcare in this country is driven by money, and we need to look at ways to incentivize, and I think we are looking at ways of incentivizing the evolution of healthcare teams. So.
Yeah, can I add on to that?
Absolutely.
Because there's a good example. A&M is the academic sponsor of a program called Healthy South Texas. Now it's been transitioned to Healthy Texas with a high reliance on community health workers. As a matter of fact, through AgriLife, which is a component of the College of Agriculture, there's work to take agricultural extension agencies and get them certified as community health workers to increase that force. Now, that sounds odd, but they often have a great interest, particularly around diet and ecology and things of this nature in a healthy environment. So the Healthy Texas has got a 10-to-1 ROI in terms of being able to reduce cost.
Yeah.
It works, and it largely is community health workers. It does not rely on physicians, and I think that these are people just making an impact, educate people in there, as you say, spending time with people with chronic illnesses and coaching them along and checking in the refrigerator and seeing, do they really have good food and things like that.
Yeah. And I think that brings up a good point about telemedicine, because we've heard a lot with that program and kind of reaching those rural areas. Right. Having, you know, I've done a video doctor's appointment before, and it was really odd because it's only us. And so does that take away from that team-based approach, or how does that either impact in a negative or a positive way?
Not at all. As a matter of fact, I think when you think about a pharmacist, does every primary care office need to have a pharmacist sitting in there? And the answer is no, but you certainly do need access. And so that access can take many forms, and the most efficient is going to be telemedicine. So one of the programs I did with Trinity was to put behavioral health into primary care offices through telemedicine. And that's often the forgotten component of our teams, is making certain behavioral health is addressed. But even since the inception of telemedicine in the 60s, actually goes way back. Ivan Thoven, who came up with the electrocardiogram, was doing it, if you will, in the early portion of the 20th century. But in the 1960s, telepsychiatry was the first telemedicine, and was very well accepted by all populations, and indeed it's highly cost effective in terms of reducing utilization.
I would suspect you deal a lot with telemedicine from the community health perspective.
My colleagues do.
Right.
I'll put it that way. Right. But yeah, no, there are a number of research initiatives and implementation initiatives going on right now. The ones I'm most familiar with through my colleagues are in the area of stroke care, but I think that has a lot of applications. But I think I was seeing some hands go up out here in the audience. So.
Right.
So I wanted to get to the question of, you said that the patient satisfaction went up with increased exposure to their provider. But on the flip side, you're saying if people practice at the top of their license, they're going to have less time with their provider. What about thoughts that somehow optimize the two, where you can increase exposure to provider? Because I know me as a patient, I do want to talk to a physician, and I kind of know the language enough to get my way with it. Is there any discussion around driving the costs of having providers, where you lower the cost that a provider is to where it's more sustainable for the healthcare system to increase, the number of providers, lower their costs to the system, their salaries or whatever, so that the patient gets what it wants, or he or she wants, and the system's costs are somewhat more sustainable?
Well, I think implicit to your question is that physician compensation is a major driver in healthcare cost. And no, it's really not. It's actually a very small part of the pie. As I've said before, it pales in comparison to the amount of waste in the healthcare system, both administrative as well as care, which is either not needed or wanted. So a good example of that is how we approach end of life. So I think that in my experience, and I think in the literature, to give you an actual example, Palo Alto Medical Foundation, all right, let's start over. MGMA, Medical Group Management Association benchmarks have an active panel size for a primary care physician, family medicine physician of somewhere between 1,900 and 2,200 patients. That's the number of unique lives seen within 18 months. But if you look at Palo Alto Medical Foundations associated with Sutter or Kaiser, that number, or Geisinger, that number gets up around 3,000. They have better outcomes and better satisfaction. And they do it through a team-based approach where everyone knows exactly what they're doing. The patients like it and are doing well with that. So it's not a matter of ratchet down provider expense, create more providers, flood the market. You still won't be able to accomplish that. One, because you can't regulate where those providers end up. Like I say, it's a vertical maldistribution as well as a geographic maldistribution. But I don't think that physician compensation or provider compensation will, and flooding the market with providers is the answer. It's, I think, a little bit too simplistic.
I would support that because I think it's the quality of the provider that we're producing. And going back to training, I think that there are many missed opportunities in how we train house staff who will become the faculty, who will become the attending, who will become the independent practitioners in terms of time utilization. When we're not training them to understand waste and adequate system utilization and systems thinking, we're disadvantaging them to be able to serve all of us as future providers. And so I go back to the education, both from the resident and fellow perspective, but even beyond. I believe that if we train students to understand that those factors matter, time spent with the patient, they'll make that time more meaningful. And then when they get into training, they look for opportunities to make that training and that rather patient experience even more meaningful. I think of our complex medical teams in the ICU. There are often 15 to 20 people going from bedside to bedside. And I, as the attending, may not always be able to spend on a given day an hour at every patient's bedside because I may be at one bedside for 3 hours resuscitating and another bedside for 35 minutes. However, when the expectation is set up for the family that we function as a team, when the team is effective, and when they recognize that, yes, the fellow is functioning with direct or indirect, but adequate supervision from the attending, so that if they come to disclose the results of the MRI, I am aware, I've sanctioned it, I've given them support, I've given them training to be able to provide them with factual information, they can at least have some confidence, not only in the system, but also the team that's taking care of them collectively.
Good. Yeah. And I'll go to the back. We'll go right here, and then I'll come right to the back again. Oh, did you have a question?
I just
go
had
ahead.
a really
Sorry,
quick
I didn't see your
question.
hand.
No, that's
You're
okay.
hiding.
I just had a really quick question, kind of going back maybe like 5 minutes ago to what we were talking about. Sorry. But when we were talking about just with the team-based approach, if you know, someone at a lower cost is, you know, doing the role of like you said, like a tech can actually do what a nurse might have been doing, and it ends up being lower cost. So it sounds like I'm wondering if you're adding more people to the system, though, in a team-based approach, does that actually end up being cheaper?
And although, go ahead. I can talk to the cultural component to it, but I defer to the experts.
Well, let me say, I think what you're looking for is outcome. And absolutely, you may be investing more in the team-based approach in the primary care environment. But if that team avoids a hospitalization, recidivism to the emergency department, lowers hemoglobin A1Cs, and a host of other kind of outcomes, the long-term savings is huge compared to the direct cost. So, but you're precisely correct. If you don't achieve those outcomes, it's a waste of money. So to the question and about what are the outcomes, how do you measure it? At A&M, we will be actually partnering with integrated health systems and saying, we're going to lower your ER utilization rates. We're going to lower your readmission rate. And we expect to be a revenue stream predicated on your savings. And so it's a partnership with integrated health systems to do that.
And I can add that as an example, right? So we talked about community health workers. We also talk about something like a scribe, a medical scribe who would come in behind a physician or with a physician and enter in notes. So one study that I've read recently has been very exciting in that especially in a primary care or a pediatric care setting, adding a scribe, yes, it's an additional salary to that team. You're adding an additional component, but it actually enables, in this case, in this study I read, was enabling primary care physicians to see more patients, right? To be able to treat more patients during the day and beyond cover the cost of that individual, bring additional revenue into the system. So not only do we have evidence behind, say, how scribes or community health workers increase the value of care, they're also, increase the perception of care from the patient side. They're also able to increase the revenue that's coming into the clinic itself.
So I had a couple of points I wanted to make about that, because we talked about physician burnout earlier as well. And one of the major contributors to physician burnout is, in fact, not being able to turn it off when you leave the clinic. And in most physicians that I know, and the literature supports this, end up spending several hours a night working on their charts, and you know, increasing amounts of time over the weekend. To the extent that having a scribe would reduce that, you increase physician quality of life, you increase productivity. One of the downsides of that is that you need to have the provider and the scribe operating in a way that does not make the patient feel like they're almost extraneous to the provider encounter. Right? When one of the major complaints about that model that I've heard and that I've read about is simply that the physician is working with the scribe and not interacting with the patient, right? So when you can strike that balance, you can achieve additional revenue, hopefully lower physician burnout, and basically have a good outcome. It's also hard to implement something like that in a small practice. Mm-hmm. It's something that's much easier to do in a larger medical system. So,
yeah, good point. Thank you. Go ahead, real quick, and then we'll go to the back. Oh, go ahead.
I've got a question from the online audience.
Okay.
This is from Suzanne Jarvis, who's an MPH student at UT. She says, new models of collaboration facilitated through community data exchanges and health information exchanges that involve care coordination of patients across providers is now happening. Are medical schools or healthcare institutions looking at this level of team building across organizations?
I'm going to go over to this side first. Do you need that repeated? Do you want it?
I was trying to, go ahead.
She's asking about, is there anything being done to teach people to healthcare providers to coordinate across institutions?
As an example, when you say institutions, you could be talking about MHMR to integrated health systems and similar type of institutions. Is that the viewpoint?
I'm assuming she's asking about across different hospitals, essentially.
Oh, across different hospitals. Yeah, I'd love for that to occur. But actually, and I think it's not as much of a political thing, because I've never talked to a physician who didn't want to do precisely that. It's usually around getting the information through an HIE or similar type of translatable database. So that kind of information. Now, Harris County does have one, as I recall.
Yeah, and I was going to say, I think Baylor's got a good,
yes, Texas.
You're all over the place.
Yes, so Texas Children's Hospital, which is where I practice actively, and of course as part of Baylor College of Medicine, has been very fortunate in that regard. We have, over the last couple of years, I don't know the exact date, it may even be longer, have implemented basically a health information exchange process. So it is as simple as if I am in the chart of one of my patients and I click a specific link, it's called Care Everywhere. And so it allows us to be able to know that this patient was seen for a sore throat and fever at this facility, even though they're one of our home patients. Why is this so helpful, particularly in the populations that I serve? Because we have very complex and critically ill children. As we often say, there are families who are functionally running intensive care units in their homes. And so we need to know that if a patient was treated at another facility because they were out of the area or because that was closest, that's where the ambulance took them, with this antibiotic that didn't work, we don't want to have to put the burden on the patient to have to remember, particularly during a time of duress. And so I think as much as healthcare systems can support, advocate for such systems, provide the resources, because it takes money to be able to implement that, particularly in such a unique healthcare environment and system as we are here within the TMC, I think it's critical.
Yes, go ahead.
Okay, hi, I'm Pearl again. So one of the things that, before coming to medical school, I did a couple of things, one of which is being a research fellow at the National Institutes of Health from the 2016 to 17 academic year, where, you know, we had an administration change that forced us to contend with us as providers, scientists, and our communication with the public about what we do. So this ties to this idea that we're talking about other people in the healthcare team and educating the patients about who those people are. For example, a community health worker, you know, there's no point in my pre-med education or the stuff that I did before coming to medical school that I learned about that except through my personal interest in public health and, you know, me taking like global health classes and kind of immersing myself in the global health community while I was at the NIH, that I came to know of community health workers actually being utilized in other countries, not here. It's actually new to me to come to med school that community health workers are utilized here. Then as I was listening, I was trying to look up, like, what does it take to become a community health worker? Like, these are really important questions, right? And here it's like bachelor's in health, all this stuff. I'm like, you know, this is some really relevant stuff that we need to be learning about. So my question to y'all is twofold. How do we better educate patients, the public of which we are a part of, about the different team players in this team that we keep referring to that are not doctors, which I think everyone kind of knows about, right? Like a little kid can be like, oh, I'm interested in science and math, like, and I'm quote unquote smart. I believe in multiple forms of intelligence, but for the sake of the simplicity of this, smart, go become a doctor, become a dentist, like these things. There's other people besides this, right? Public health professionals, all this stuff. Even a scribe, like, I don't know if all patients are interested. If I'm in the room, I want to know what each person is doing, like what, you know what I mean? And I think it'd be really great if people could. So that's the patient side. Then the provider side, which I think everyone on this panel has been touching on, is, you know, how do we, among ourselves, understand what the top of licensure actually means? Because there's some confusion there. And from my perspective, being a student, I haven't, again, my knowledge of other people's scope of practice is through my social interactions and my questioning. So, and because of the curiosity, but this is just so important. Like, you know, I've FaceTimed with these people, you know, as professionals too. So it's just, you know, twofold. I don't know if you're following me. I have a.
Yep. So I'm going to recap. So let's go to number one. How do we better educate the public about these team players that may be part of the healthcare team that patients might not be as familiar with?
My dissertation was on community health worker training, and I think a big part of it, whether you're talking about community health workers or scribes or other individuals, as these professions are getting much more well established and much more integrated, and patients, to speak to your point earlier, sir, about you know, I want to see the physician. As the patients experience a culture change of being treated by a pit crew, you don't get a cowboy that comes in and rescues the day. You get a pit crew of people who are there to provide you with the best possible care. There's a bit of a culture change that happens on the patient side. So one of the important components is for each of the professions to be able to articulate specifically what the top of their licensure means. And especially when we talk about within social work or within community health workers or when within these professions that are relatively new to a traditional clinical setting, it's really important that the professions themselves have a coherent message behind the type of care that they can provide so that they can preach that message. And so that is an ongoing challenge in that area, I think.
You want to add?
Yeah, I just wanted to add a couple of things and maybe pose a question back to the panel myself. One is that I'm not entirely convinced that the patient looks at a care team and tries to identify people by what their title is. I think they look at a care team and want to know that they're getting the answers to their questions and that they're getting the proper, that they feel like they're getting the interaction that they need and the information that they need, okay? So that's one point. The second point, and which is really the question back to the panel, which is when you are trying to build a team environment, how do you empower the team members to make decisions so that decisions don't go back to the cowboy who has traditionally led the team, so that a community health worker can make the decisions that they are basically empowered to make by their training, right? And have the confidence that their decision is going to stick, right?
I think we can look to the industrial organizational psychology to better understand this, and in terms of, and Dr. Coleman can speak much more eloquently about this, I'm sure, but the idea behind psychological safety being such an important component of team care and of team functionality, the idea that I can speak up no matter who I am on the team when I know what's best for the patient. This is such an integral part that's necessary to develop, or else you're right, you are going to have a hesitancy, right? If you feel like if you speak up or say something or take care of something, there's going to be a negative consequence. You're not going to step up and take that role, which I think goes back to the culture change that is inherent in our current practitioners, right? This is needed with our current practitioners to be able to understand that they are part of a larger team.
So real quick, you do a great deal of education on, and I don't want to get too far into this because we can talk about this for the whole hour, different generations.
Yeah.
So from the generational aspect of those existing providers
Sure.
who may not have had, they are the cowboy type of provider.
Sure.
How do you engage that piece when you're talking about the cultural change and the up and coming, where they're coming out of medical school or other primary care programs that are getting this sort of shoved down their throat? We have to act as a team.
Sure.
How do we do that?
How do I do that?
Yeah, in 15 seconds.
In 15 seconds or less, ready to go.
We only have 20 minutes left, so you've got to make this quick.
There are 5 generations currently practicing in any workforce, and specifically in healthcare. If you look at the greatest generation or the baby boomers, for example, their reception, how well they receive feedback, they actually consider feedback to be either offensive or it's completely irrelevant to them. Versus the next generation, Generation X, wants feedback, but they go to their boss and say, please give me feedback. Versus the millennials they expect continual feedback on a regular basis, compared to the Gen Edge is what comes after millennials, and they change their behavior based on the feedback that they get and immediate consequences. So the reality is, when you're talking about how do I answer that question? That's really fast. If you're talking about these culture change, you have to take into account, for example, that if a baby boomer says at the end of a day, I'll see you tomorrow, to a millennial, that might be them giving positive feedback of, you did a good job today, right? I think the reality is that everyone who is practicing has the same goal in mind, which is the best possible care for the patient. And if they become self-aware about the differences between generations, it could help bridge that communication.
Perfect.
So come to my class.
Perfect. Did you want to add something, Dr. Coleman?
I really love what Dr. Uriarte said, and I will come to your class because that concept of self-awareness is very true. I mean, can we talk about the fact that we are living in a completely different world? I'm not that old. I'm not old. But training is very different than it was. I remember my first night on call. I had 5 critically ill patients coming in and no idea how to run the machines or do the procedures that were required. My attending, wonderful program, said, good luck, call me if somebody dies, unexpectedly. And we muddled through the night. And it was through my interprofessional, intergenerational partners who were the ones who said, okay, well, this is what we're gonna do with the oscillator. This is where we get the line kit. This is how much epi we draw. And humility is, I think, grotesquely missing from medicine of today. That understanding that Dr. Brown has been an intensivist, with all due respect, for a lot longer than I have. And there is always something that I can learn from that generation. I think, unfortunately, the demands of medicine from all of us often make us, and particularly the more junior you are, feel that you have something to prove. You have to demonstrate that you have all the answers, so that it becomes not okay to say, I don't know. But I would argue that that has to become normative, so that the intergenerational learning and the interprofessional learning is what actually underlies our work. Recognizing that a 30-year nurse in practice is going to know more about critical care medicine, despite the fact that I may have an MD, because that person has been doing it. And there will come a point where that person may look to me to lead the team, but that knowledge acquisition is, and respect is something that has to be earned.
Let me tag on to this. Thank you for saying humility. It is absolutely a critical part in team-based approaches. And I too am an intensivist, and that was clearly pounded into me early on. And I think that in a team, humility and mutual respect of the roles. You have to understand what the roles are. You have to understand their training. You have to understand their background, which is the reason why A&M is doing interprofessional education. And as an example, using medical students, pharmacy students, and other kind of students to do community health work with supervision, and also going to patients' homes to see what it is like to do a home care visit on someone who's really chronically ill. So those are the kind of interactions, and they're learning what the contributions are. They have very specific roles as they go forward. They're getting formal training in the differences in the education and in the roles. So hopefully it'll stick as they go forward in their residency and future lives.
Good. Are there any more questions? I don't know if okay, right there, I was saying. Okay, sure.
As a baby boomer, and I was struck by, I'm not going to say your name,
Jessica. Just Jessica is fine. Yeah.
If you had asked me what my team would have been, I would go back to my first job as a nurse. I'm faculty at Texas Women's University, and think of myself as a public health nurse, an ICU nurse, a trauma nurse, a nurse scientist, nurse researcher, and educator. However, my first job as a nurse was as a Navy nurse. And I would have said my team was the corpsmen, the physicians, the nurses, the chaplain, the dietitian, the family, the patient. And so I just am so delighted, because none of us want to work in silos, and we love the collaborative interprofessional learning, and we can all learn from each other.
Well, and I think you brought up a very good point there with adding the patient and the family. We forget that's now part of team-based care, because they have access to these things that they're constantly telling you what they want to take and what they need. You know, I need an MRI. This thing said I need an MRI.
And I realized that in the military, we didn't have to worry about, and we had that thing called rank. So there was that inherent respect there, but also, the value-based and the, see more patients and all of that was a different world, and that we have to be able to figure out how to deal with that and work together.
Yeah, fantastic. I do want to touch on that patient piece very quickly. How much, in a perfect team-based approach, so let's say we have the proper team, how much interaction should the patient have? Should there, they should obviously, as a patient, I would think, have some impact on their care and be a part of that discussion. At what point are they the proper part of that plan? Beginning, middle, end? Do they provide that information? Do they wait on the team? Do they wait on the right person to kind of say what their care should be?
Well, I'm going to draw it back a little bit, because if you begin to look at NCQA requirements and current good examples of primary care medical homes, PCMH, but there's a lot of different variations on that theme, but a consistent component of that is a patient family advisory committee. So they have an impact not just simply on their individual care, but actually on the conduct of the practice and giving direct feedback in fairly real time about what's going on and improvements, and keeping alive the idea. It really is about the patient and their families, which is a critical element on that. So how much is enough? Let me be kind of provocative here. In an ideal world, the patients who typically see their physicians about 2.5 times per year, maybe 2.2 to 2.5, and they're middle-aged or so forth, what you want to do is reduce that. You want to make certain that you do wellness programs, you have registries, so that individual can be handled almost outside of the clinic by the team, and make certain that their diabetes is under control, their hypertension is under control, and so you want to diminish that contact with the physician, if that's it. Whereas they can have electronic contact with their other team members, and you actually begin to reduce actual cost of care through that as well.
Good.
So very provocative, and I like that. I function only really within the realm of inpatient critical care medicine, so I'll limit my perspectives there. So I've talked a little bit about values-based care to be differentiated from value-based care. Values-based care, thinking about what does the patient want. There are patients who want time to digest information, who want to, for their own personal reasons, not be immersed in the system twice, 3, 4 times a year for their hypertension. Think of the example of monitoring for INR or bleeding time for patients who receive anticoagulation. Not as much a part of our pediatric population, but for some. There are patients who like going to the laboratory because they might be socially isolated otherwise, and that once-a-month testing provides them with the opportunity to be around other people and to be seen and to be cared for. There are others for whom that's burdensome, that makes them feel that they're sicker than they are, who prefer the convenience of measuring in their home and receiving a call from the doctor and follow-up. I give that example to say that I think, if I have to be honest, it varies. I think there's some patients who are served better by their own values and their own design by having that frequent contact. It's kind of like health insurance system or mortgage insurance for that matter. A lot of people pay into the system. Some people use it more, some people use it less. And I think if I can challenge the point that Dr. Brown made for the interest of discussion, I would say let it be up to the patient.
Okay, that's great. Good. Yeah, you're good? Okay, perfect. So we have about 7 minutes left, and I want to ask one more question of our panel, and it's really about the future. So we've talked about current a lot. We've talked about the future a little bit, but how do we manage the human response to change? We don't always like change. So from a perspective of knowing that it's going from, I want to see my doctor, to creating this mentality in a patient environment where these are skilled, qualified, adequately prepared team members that are going to take care of you. How do we do that in a way when either the patients or the provider might not like change? You want to jump in? Because I know you do some with change. So why don't you kick that one off?
Well, I think that you start with things like behavior change science or industrial organizational psychology and look outside of healthcare to understand how humans deal with change in general, and understand that the reality is there are several components needed for someone to enact change over a long period of time, and the most important is having an internal reason why, right? So I think that as we were talking about team-based care, if I can't see the physician, if I really want to see that physician more often, right? I want that face time with the physician. Having the understanding of how my care is better served with the entire team is part of the education that's needed, so that component of change management for the patients that are coming into the clinic, making sure that they understand why we having that reason why. No one likes change forced on them, and if we are having to change and our capacity to interact with our providers is changing, it's really important that we have that education component to make sure we're all collectively communicating why it's so important that we have all these different providers that are now part of the system.
For me, I think what we're talking about is maybe a little bit of conflict management as well when you begin to introduce some of these ideas. So I think that there's a few concepts here. Keep the discussion patient-centric, not provider-centric. Articulate a very clear and compelling vision of why we're doing this, and do it 50 times. Be ruthlessly data-driven. In other words, you put up patient experience scores, you put them in the lounge, you show exactly on a bar graph who is who. Be ruthlessly data-driven, who's controlling the diabetes and the hypertension. All providers respond to that very well. Re-articulate the goals and vision every time you get together. Keep it brief. And Max Weber was a German sociologist in the 19th century, and he really gave 4 principles to really get people engaged. Is to make certain that they're engaging in a noble purpose. That's that articulated vision that you want to do. To satisfy self-interest. Hey, we got to eat. And making certain that your compensation plan really addresses outcomes, meaningful outcomes. To earn respect, so that they're respected and acknowledged in their organization, and to embrace a tradition of excellence. So you have to, that's the hardest part. For instance, if you think about the Mayo Clinic, yeah, they've been doing it a long time. It's easy to talk about the Mayo way and address that, but to really kind of getting that flywheel going, you have to develop a tradition of excellence, patient centricity, being data-driven, highly objective, get the emotion out, and I think then you can begin to do that. How long does it take? In my experience, it can take 2 years, and seen amazing changes occur within 24 months.
So I echo all that has been said by my partners in the panel. I'll speak from the patient perspective. Set expectations early. Be mindful of what we've talked about, mutual respect and humility. Be consistent, yet be adaptable. But at the end of the day, I would just say, honestly, one thing, humanism. Bring back humanism. It is about the patient. It is about the provider. At the end of the day, we are all people. I think patients understand, I want to be able to spend more time with you today, but I have another emergency, so I'm going to come back. Or, today I'm leaving on time because I need to do something for my child. I always say there's a very thin line that separates us. The white coat is superficial. At the end of the day, I think people are people, and if we treat each other as such, I think we would be surprised by the tremendous grace and understanding that we could give each other.
Fantastic.
The only thing, I second everything that everybody has said much more articulately than I could. I think one of the starting points is just to acknowledge that care delivery is changing and can change and has to change in response to our changing foci on cost reduction and reimbursement based on care quality. And as the systems change, I think that the people in the systems have to acknowledge that the change is coming and that it can be done.
So again, since I didn't formally introduce myself at the beginning, and now that we're at the end, I'll do that. So Trevor Burt, I'm the VP for Education over at Houston Methodist, and We have seen a lot of this, and I think, by adding Jessica to our team, this has been something that we've had an opportunity to really take a look at as an institution. We don't, now we have A&M medical students, but we didn't, through the Baylor split, and I think it gave us pause to figure out what that looked like. And having medical students back full-time, having residents and fellows that are there full-time, that part of that team, having nursing schools that rotate in, and a very productive pharmacy program. I think we've taken a step back, and last year started a Interprofessional Education Day, which has now gotten a new name, but really engaging each of our groups and seeing that from sort of the Institute for Academic Medicine as a global entity, and figuring out how do we work together in an environment where it is going to impact the patient in a positive way, or the family, or each other. And so as we start to do that, I think every institution could benefit from that. I know A&M does that just from our interactions with them. I would assume that everybody's starting to go that direction, knowing the importance of it, and knowing that without team-based care, those operations are going to fail. There's only so many hours in the day, and so thank you again for the questions. I want to thank especially my panel. This has been fantastic. You always think there's no way we can fill an hour and a half, and we've now filled an hour and a half. But thank you to each of you. You each brought something that was very valuable. And if you have any additional questions, we're happy to take those afterwards, but I know that this ends our time. So thank you very much.